Thank you, Tony, for a great talk. I'm going to invite Andrea up to come up and answer some questions. Maybe while people are coming up, I'll just say I think that the increasing or resurgence of interest in disaccharidase deficiency and GI symptoms is really interesting. 30 years ago, Fred Weinstein always said, remember sucrose isomaltase deficiency. And we remembered it, but we didn't really do anything clinically with it. What we did clinically was, say avoid lactose in your diet or take lactase pills. And we all knew that there was this dose-response relationship and probably other unknown factors that made all of us who are technically acquired lactase deficiency. That's how we used it clinically. Now you can do a duodenal biopsy, you can send out, get a commercial test. There's a commercially available yet probably very expensive sucrosidase available, which maybe is part of the recurrence and interest. I'm just wondering, clinically right now, how do you approach this with your IBS patients? Is this something for everybody or a selected group?
That's a really great question. I think we're seeing much more interest in this and patients ask about it too. I don't actually send my patients for biopsies, at least the adult patients. I think they do this more in pediatrics just because of some of the known challenges. And sometimes it's just as convenient to trial some specific elimination diets and gather some empirical evidence there. So I'm more likely to just go to diet modifications rather than testing them specifically for deficiency or even putting them through the breath test, which we showed does have some performance characteristics limitations.
Tony, any other thoughts?
No, I agree. I think that the testing can be difficult. Breath testing data suggests 20 to 30% of people seem to be positive that have IBS-related symptoms, and the biopsies seem to be less, but as you said, it's difficult to do, it's expensive, and it has issues. Of course, if you don't do it the right way, it's not on ice, the enzymes will degrade, so you can get false positives. The enzyme that's currently available is FDA approved in children, not adults, right? It's very expensive, but it's not going to end there, right? Enzymes can be made. And there's a lot of interest in making these enzymes much cheaper, and these are things that can be over the counter. So I suspect, I guess, that there'll be many other options coming in the future.
Yes, Kelvin.
So two quick questions. Thanks for your talks. So the first one for the disaccharide enzyme deficiency, and you do the biopsy. Just curious, in your practice, where do you send them? I have one particular case I'm about to do that, and I'm kind of trying to figure out where I'm going to send my biopsy. And the second question, I'm glad you brought up the population of patients with Parkinson's disease and constipation. I do find them very challenging to treat them. The only successful medication that I have right now is prucalopride, and I think this is the only one population that I try to push the limit a little bit above the recommended dose, up to 4 milligrams. But in your practice, any tips that you can bring up, particularly for this population?
So for your first question about the DISAC assay, I don't use it often clinically, but when we did it for a research trial, the way that I found out how to get it done was asking our pediatric colleagues. And so if you have any pediatric colleagues, you may ask them where they send their assays, and that probably will give you some if your lab doesn't perform it. Regarding Parkinson's disease, I think this is really more of an emerging area. There's not really any data-driven algorithm in terms of how to manage constipation, specifically in patients with Parkinson's disease. So we probably extrapolate a lot of the typical standard management for chronic constipation. I think prucalopride probably makes some sense, but in the original trials, especially in older patients, we're advised to use a lower dose, which is the 1 milligram, but it's been proven to be pretty safe in terms of risk profile. So I have seen people use higher doses of it, but we probably won't be formally recommending that in any sort of guidance document yet.
Thank you.
Okay, thank you. Oh, one question, Richard.
Yeah, I mean, IgE would be an allergy. So if they have allergic type symptoms, sometimes it's, and even in the food allergy realm, sometimes it's, and I don't know the numbers at the top of my head, sometimes it's only GI related and not systemic. But that's rare, right? But if it's that's a true food allergy, it's very, very rare to see, particularly in adults. So we don't generally recommend IgE testing. IgG testing, we don't recommend either. You saw the guidelines. The new one may be the better one to use, but that hasn't been proven yet.